Welcome students to this session where we will be discussing refractive errors. Our learning objectives for the day will be to define, classify and describe the types and methods of correcting various refractive errors. We will also discuss about the indications and the principles of refractive surgery. Also the role of refractive error correction in a patient who has headache. So talking about refractive errors, it's important to know that an eye is actually a convex lens, that is conjugation of cornea and the lens of the eye. It behaves like a convex lens so that the rays that are coming from infinity can be converged onto a point of the retina, that is the center of the retina called fovea, for perfect and clear vision. Now the cornea has a refractive power of around 43 diopters and the lens has a refractive power of around 25 to 27 diopters, which makes the total power of the eye plus 60 diopters. Now, if suppose the eye is slightly elongated or slightly smaller, or the cornea is deformed or the lens is misplaced, then the parallel rays of light which are coming from infinity will not be focused on the fovea. So what is emetropia? Emetropia is when the parallel rays that are coming from the infinity are focused onto the retina to provide clear vision to a person. But refractive error or ametropia is when parallel rays of light which are coming from infinity are not focused on the retina. Either they are focused in front of the retina or the back of the retina. Now talking about the position of the lens inside the eye, the lens is placed right behind the cornea. If the lens moves posteriorly, the focus of the rays will move posteriorly. If the lens will move anteriorly, the focus of the rays will actually move anteriorly. So that is how the position of the lens is also important inside the eye to cause ametropia or emetropia. Now talking about the most common refractive error, that is myopia or short-sightedness. Short-sightedness is when parallel rays coming to light are actually focused ahead of the retina, with accommodation being at rest. It's important that when a person accommodates for near object, the rays that are actually coming from near of the eye, they are also getting focused on the retina. How does that happen? That happens because the thickness of the lens increases because of accommodation. So this is a very important factor in having good near vision as well as good distance vision when a person is younger. As a person's age increases, the deformity of the lens that can happen decreases because of thickening of the lens fibers and weakness of the ciliary muscles. That is when your accommodation starts decreasing and you start having presbyopia. So a person who has myopia is already actually focusing the light in front of the retina. As the object of interest moves near, the focus of the light automatically shifts behind without even the person accommodating. Therefore, myopes, they use very little of accommodation. And myopia can be divided into three types. It can be mild, moderate or severe. Up to minus 1.5 diopter is mild myopia. 1.5 to 6 diopters, minus 6 diopters is moderate myopia. More than minus 6 diopters is high myopia. And if it is more than minus 8 diopters, that is a pathological myopia can set in. According to the causes, it can be congenital, simple myopia or pathological myopia. Simple myopia is when there are no changes in the fundus that can lead to permanent visual loss in a person. But pathological myopia is when there are changes in the fundus that may lead to poor vision eventually in a person because of excessive elongation of the eye. Mechanisms of myopia are axial myopia. Axial myopia is the most common type of myopia. It happens due to elongation of the eyeball. A 1 millimeter increase in the axial length causes 3 diopters of myopia. So this is a very important question. Second is curvatural myopia. Curvatural myopia is not very common. A 1 millimeter increase in the corneal curvature can lead to 6 diopters of myopia. It can happen when a person has keratoconus or has lenticonus, or there is a cone actually in the lens. The lens thickness itself is very high. Index myopia is a common myopia that happens in people who are developing early cataract. When people are developing early cataract, in the lens, the center of the lens, that is the nucleus of the lens, the refractive index, it increases because of thickening of the nucleus fibers. That can lead to a change in the refractive error causing index myopia. That means a person who had good distance vision and was able to focus the light on the retina, because of increase in the nuclear sclerosis, now the light will actually focus in front of the retina. But for near objects, there are already divergent rays that are coming. This focus will actually shift onto the retina. So the distance vision will reduce and the near vision will improve. A person who was earlier presbyopic and was using glasses for near might not have to need glasses for near anymore, but he would need glasses for distance. Eventually, as the nuclear sclerosis increases, as the cataract progresses, then this person will need a cataract surgery. Now coming to positional myopia. In positional myopia, there is anterior displacement of the intraocular lens. So if the cornea was placed here and the lens was here, and this is the retina, the rays that are coming from the parallel rays that are coming from infinity were actually focused onto the retina. But if you place the lens anteriorly, this focus will automatically shift anteriorly, causing myopia. So anything that causes the rays to focus ahead of the retina, that is causing myopia for us. Now, what are the symptoms of myopia? When a person comes to you with myopia, what are the symptoms? In mild to moderate myopia, a person can just not see clear at distance. In children, what happens is that teachers usually tell that this child is not able to look at the blackboard, or the child comes and tells you that he is not able to look at the blackboard when he is sitting behind, in the behind seats. He has to sit in the front seat to see what is clearly written on the blackboard. So this is a most common complaint that you will get in children who are studying in class 8 or 9 or 10. When they start developing myopia, this is the most common symptom of mild to moderate myopia. The near vision is usually good because they do not have to accommodate for the near vision, and also because they have a slightly minus refractive error and there is no need to accommodate. There can be accommodation insufficiency or convergence insufficiency also that might be present in people who have mild to moderate myopia. They usually partly close their eyes to look or see clearly. When you partly close your eyes and you try to look through the pupil, you artificially actually create a pinhole through which you try to look carefully. What a pinhole does is it moves the circle of least diffusion to near of your retina. That is why a person is able to see clearly through a pinhole or closing their eyes to look when they have a refractive error. Now in severe myopia, what happens is they cannot see clear for distance as well as for near, because if there is a 6 diopter of refractive error, then the near vision will also be poor. They usually have poor performance in school, these children, and they hold the objects very close to the face to clearly read or look at them. So it is very important to pick them up early and give them glasses. So what happens in pathological myopia? Pathological myopia is more than -8 diopters of myopia. When there is more than 8 diopters of myopia, the eye is elongated too much. The axial length is usually more than 26 millimeters, and while the normal axial length is actually around 22 to 24 millimeters. The Posterior part of the eye elongates much more than the anterior part, which can lead to formation of posterior staphylomas. In posterior staphyloma, the posterior part of the eye is not round, but one part is bulged and the other part is actually round. So there is a difference in refractive error which might be present at the base of this staphyloma and other parts of the retina also. There are very prominent eyeballs. The child's photograph which was placed in the previous slide here, see this child, he has both eyes very high myopia, pathological myopia. That is why the eyes seem that like they are bulging out from the orbits. There might be sluggish pupillary reactions. There is usually very deep anterior chambers. Because of very deep anterior chambers, there are multiple problems that a person can have, especially if you have to do a cataract surgery in a myopic person. It is difficult to operate these people sometimes because of very deep anterior chambers. There can be vitreous floaters. The vitreous jelly which is usually lining the retina, because the eye is progressively elongating, it forms vitreous floaters which is called muscae violentis. Then there are various fundus changes that can occur. There is rapid elongation of the eyeball to which the retina and the choroid are not able to adapt very well. That is why there might be a tilted or an abnormal looking disc. So this is a very large optic nerve head or very large disc. This is a very large disc, and there is a peripapillary atrophy which you are able to see outside of the disc. So the peripapillary atrophy and large disc or tilted discs are usually present with pathological myopia. Then there can be Foster Fuchs spots or lacquer cracks. Lacquer cracks are breaks in the Brooks membranes because of elongation of the eyeball, and Foster Fuchs spots are previously healed CNVMs that might be present, or there is a RP hyperplasia that is present over the retinal pigment epithelium. So these spots might be present. Also, as you can see here in this area, the choroidal vasculature, the prominent choroidal vasculature is very well visible. This is called a tessellated fundus, or there is a chorioretinal myopic degeneration. So this tessellated fundus is a classical finding of pathological myopia. Coming to treatment of myopia. So now, because when we saw what happens in myopia is parallel rays of light are actually being focused in front of the retina. Therefore, we need to diverge these rays more so that the focus shifts posteriorly. To diverge these rays, we use concave glasses. Concave lenses, what they do is they diverge these rays so that now the focus is actually on the retina itself. It is very important to never overcorrect myopia, because myopes, they usually have lesser accommodation because they are not using their near vision properly. Just without using their accommodation, they have been doing all the near work when they were not using glasses. Therefore, when they try to accommodate, they will have severe asthenopic symptoms or brow ache or headache if you overcorrect myopia. So you should slightly undercorrect or give exact correction and never overcorrect myopia. Contact lenses are better in myopia because, see, in this child there are very thick glasses that he is using, around -14 diopters, and in these cases a very high myopia, contact lenses are very good option for us, because if we are using minus glasses usually minify the images. You can see that the side of the child's face is visible through the glasses. So the minus glasses usually minify the image. Minification of image is not seen in contact lenses. Also, low dose atropine eye drops are nowadays available, and they have been shown to prevent progression of myopia in childhood. In children who are less than 10 years of age, and they have been shown to have progressive increase in the minus glasses over the past year. There you can prescribe low dose atropine eye drops twice daily or once daily, which have been shown to not hamper the person's accommodation so much, but they prevent elongation or rapid elongation of the eyeball. Refractive surgery can also be done in adults who have myopia, which will be discussed later. Hyperopia is called farsightedness. So here what happens is that the parallel rays of light that are coming from the infinity, they actually tend to focus behind the retina. Now the person who has hyperopia has a very good mechanism of making this go away. What the person does is he accommodates even for distance vision. So distance rays are coming parallel. So the person accommodates and makes the lens slightly thicker so that the rays that were focused behind are now actually focused onto the retina. Therefore, a hyperope will accommodate for distance and he will also accommodate for near. If a person has 3 diopter of hyperopia, he will be accommodating 3 diopters for distance vision to see the things clearer. And for near vision at 33 centimeters, additional 3 diopters of accommodation. So total 6 diopters of accommodation will be needed for a person who has 3 diopters of hyperopia plus 1/3 of a meter. When he is seeing at 1/3 of a meter, 3 diopters of accommodation. Again, more he will be using. So what happens, what problems happen in hyperopia is that when they are younger and they have very good accommodative amplitude, they are able to see for distance and near. But this only happens in mild to moderate hyperopia and not in very severe hyperopias where the eyes give up because they are not able to accommodate so much. So in mild hyperopias, they will accommodate for the distance and they will accommodate for near, and this will lead to headaches and strains. This is what is happening in hyperopia. Now, what is the mechanism of hyperopia? Axial hyperopia opposite to myopia. The eye will be smaller in size. Curvature of the cornea might be flat. The lenticular curvature might be flat. The lens thickness might be lesser. In index hyperopia, the refractive error of the cortex of the lens may increase relative to the nucleus. And in positional hyperopia, there might be posterior displacement of the lens. Symptoms of hyperopia, as I have already told you, because there is excessive accommodation for distance as well as near, there will be eye strain. So earlier when they are able to accommodate for distance and near as well, the people will have eye strain. And the first vision to go will not be the distance vision, will be the near vision. A 35-year-old might come to you and say that he has presbyopia, but that person usually will actually have hyperopia unless there are some other causes. So a cycloplegic refraction is usually needed in hyperopia so that the ciliary body, which is accommodating too much and causing too much eye strain, that can actually be alleviated to look at the refractive error. There might be rubbing of the eyes because in the evening, in the morning, the person has very good accommodative effort, but as the day goes by, the ciliary body, it gets tired. And that is why in the evening, the person has intermittent blurring of vision because the ciliary body gives up in between. It again tries to accommodate and make the things clearer. So the person will have intermittent blurry vision. People tend to rub their eyes with dirty hands. Therefore, they can have recurrent styes, chalasia or blepharitis. Then a latent convergent squint might develop if there is excessive convergence that is present. So signs of hyperopia is because the eye, usually the hyperopia occurs due to a smaller eyeball. If there is a smaller eyeball inside an orbit, obviously the palpebral aperture will be small, the cornea will also be small. The anterior chamber of a small eye will have a normal sized lens because the origin of the lens is from the ectoderm, and the size of the lens tends to be almost similar in all of the people. But when it is fitted into a smaller eye, then it causes shallow anterior chamber. There might be a small optic disc with crowding of the vessels. Sometimes smaller optic discs might also have indistinct borders because all the ganglion cells, they are trying to fit into a very small optic disc, which is called pseudopapillitis. And the size of the optic disc can be confirmed with the size of the optical circle on the direct ophthalmoscope, which is discussed in the basics of fundus examination lecture. The retina, it might have a silk shot retina appearance because because in a smaller eye, the retina is very well packed and it gives you a very shiny appearance. Now coming to components of hyperopia. So components of hyperopia are important to understand because I have told you that hyperopic people, they have excessive accommodative effort. They make their lens thicker so that the distance vision can become clearer. The total hyperopia is actually the hyperopia. There is total hyperopia which can be divided into latent and manifest hyperopia. Manifest hyperopia is further divided into facultative and absolute. So when a person presents to you, he actually presents to you with absolute hyperopia. There is a part which he is correcting by his own accommodative effort, that is the facultative hyperopia, and absolute hyperopia is the part which is left and it cannot be corrected by the person's own accommodative effort. When you combine these two, then it becomes manifest hyperopia, which means this is the hyperopia which we need to correct. Now, because the ciliary body has its own tone, inherent ciliary tone, it is 1 diopter. So, plus 1 diopter of actual hyperopia, of the total hyperopia, is corrected by the inherent tone of the ciliary body. You do not need to correct this hyperopia in normal children. You do not need to relax the tone of ciliary body in all the individuals. But when you have a child who is coming with squint, especially esotropia, in those children you need to alleviate the or decrease the ciliary tone also. Therefore, in those children you correct the total hyperopia, but in people who are coming to you with simple hyperopia without any squint, there you need to correct the manifest hyperopia. So the treatment of hyperopia is convex lenses, because you know that the when the parallel rays are coming, they are actually focusing behind the retina. To make these rays more convergent, you need a convex lens, just like you try to focus the sunlight to burn a paper using a convex lens. If you have to focus the light in front of an object, then you have to use a convex lens, and it's important that complete correction of hyperopia is given. Cycloplegics are very important, especially for use in children. When you're using cycloplegics, especially atropine, it's important that you give ointment for atropine and not eye drops, especially in younger children. And you also counsel the parents for side effects of atropine, which are common, like fever or dryness of the body, or there might be bradycardia, or the child might have some irritative symptoms in the body. So these you have to counsel the parents for. You can use contact lenses also in hyperopia to use for the wider field and less magnification of image. So plus lenses, they always magnify or enlarge the image. So this is very important. Refractive surgery for hyperopia is discussed later. Now talking about astigmatism. Now in astigmatism, why does astigmatism happen? It happens because the eye is not a 2D structure. So the rays don't just come from the top and the lower part of the cornea, but they also come from the sides of the cornea. So the cornea is a round structure. The rays are going from the rays are going from the side also, and the rays are going from bottom also. So when the focus of the two rays is actually different at different position of the eye, then it is called astigmatism, when different meridia of the cornea are actually focusing the rays differently. It is called simple myopic astigmatism when one meridian of the cornea is focusing on the retina. It is called myopic when the other one is focusing in front, and simple hyperopic when other one is focusing behind. Compound myopic and compound hyperopic is when both the meridia are focusing ahead is called compound myopic. When both the meridia are fixing behind is called compound hyperopic. It is called mixed astigmatism when one meridia is focusing in front of the retina and the other one is focusing behind the retina. It is called regular astigmatism when the principal meridia are parallel to each other, which means that on the cornea, one meridian is say at 90 degree and the other one is at 180 degree or 0 degree. This is a regular astigmatism. Irregular astigmatism is when both the meridia are not perpendicular to each other. Now coming to the causes of astigmatism. Causes of astigmatism is, it can be congenital because of simple difference that is present in the curvature of different meridians of the cornea. Pterygium, when pterygium happens, it pulls the cornea on one side and causes astigmatism to occur on the cornea. If there is a wound over the cornea like a SICS wound or a scleral wound which is present on top of the cornea, then that can also lead to astigmatism in a person. In glaucoma surgery, we make a flap. There is ostium which is made in the sclera through which the aqueous can flow out. So there is some sort of weakening of the cornea that happens in the superior part that can also lead to astigmatism. If there is constant rubbing of eyes that happens due to allergic conjunctivitis, especially in children, alleviating itching is more important than alleviating the allergy itself, because rubbing of eyeballs has been proven to lead to keratoconus in children who keep rubbing their eyes for a very long time. So the signs of and symptoms of astigmatism are usually headache and eye ache, and there is fatigue on reading, and persons who have astigmatism with steeper or flatter, very steep or very flat astigmatism, then they see that the letters might be running together. So the goal in astigmatism is to find where the circle of least confusion is. A mixed astigmatism usually has lesser symptoms. Why does mixed astigmatism has lesser symptoms? Because one of the rays actually focus behind and one of the rays focus in front, and there is a circle of least confusion that is present in between those two meridia, and that falls over the retina. That is why mixed astigmatism usually has lesser symptoms. Whenever we are doing refractive correction in any person, our goal is to place the circle of least confusion over the retina. Also, the pinhole does the same thing when it reduces the amount of light that is coming into the eye. Although the focus is happening on the same area, but the size of the circle of least confusion, it decreases. The treatment of astigmatism. If the astigmatism is less than 0.5 diopters, it may not need spectacle correction. If it is more than or equal to 0.5 diopters, it usually should be prescribed over the cornea in the exact axis. How do you measure the axis? When you are doing refraction, usually the left of the eye is taken as 0, the right of the eye is taken as 180 degree, and that is how you measure the degree at which you have to give the astigmatism correction. Contact lenses itself, when they are placed over an irregular cornea, the corneal curvature is such in the vertical meridian, but in the horizontal it is like this. When you place a contact lens over the eye, it automatically corrects some of the astigmatism that is present. Refractive surgery can also be done for astigmatism. Now coming to aphakia. What do you mean by aphakia? Absence of lens in the eye is called aphakia. The most common cause of aphakia is actually surgical. It can be traumatic also. Post-trauma, either the lens, it ruptures or it floats into the vitreous, subluxates into the vitreous. Congenital aphakia is usually very rare. In aphakia, the eye becomes highly hyperopic. The usual aphakic correction which we give to the patients may range anywhere from +10 to +15 diopters. There is complete loss of accommodation because there is no lens, therefore the near vision of the person also decreases. The change in the power of the eye from 60 to 44 diopters, because only the cornea is now acting, therefore the rays are focused much behind the eyeball. The symptoms of aphakia is poor distance vision as well as poor near vision. There is bluish image appearance because of the absence of lens, because blue and infrared spectrum is able to enter the eye more because of absence of the lens. There is a very deep anterior chamber. There is iridodonesis and jet black pupil. If you look at this video carefully, There is a jet black pupil that you're able to see. The anterior chamber is deep, and when the patient blinks the eye, the iris moves. So this is called iridodonesis. This person actually had undergone ICC in a very old time, and she's an old patient who's around 90 years of age. So both eye aphakic correction she is wearing. Now coming to treatment of aphakia. Treatment of aphakia can be done with spectacles, because you're giving such high powered spectacles. There is a lot of magnification of image that can usually happen, around 30 to 33% image magnifications. Image usually looks very large. So when people are moving on the stairs, there might be people might slip, and the falls can be related to this. Also, because the lenses are very thick, there can be a prismatic effect of the lens, because at the end of each lens there is a small prismatic area which is present, which behaves like a prism. So there is prismatic effect at the edge of the lenses which happens, and it shifts the image. There can be jack-in-the-box phenomenon or roving ring scotoma that might be present at around 40 to 50 degree of the visual field of the person. There is limited field of vision because of the prismatic effect of the lenses. Contact lenses are better tolerated by aphakic persons. Intraocular lens implantation can be done in such people. If when you dilate the pupil in an aphakic person, if there is a sulcus or the previous rex's margin is present behind the iris, then the lens can be placed in the sulcus, or a scleral fixated lens can be put, or an iris fixated lens, or a AC IOL, anterior chamber IOL, can also be put in a aphakic person. Presbyopia is fall in near vision, which happens due to reduction in the accommodative power of the lens. The age-related decrease in lens elasticity is the cause of presbyopia. Now, the normal, at 20 years of age, a normal person can accommodate around 10 diopters, and the near point in centimeter is 10 centimeters. So, to look at 1 meter, if a near object is placed at 1 meter, the amount of accommodation needed is 1 diopter. If the near object is placed at around 1/3 of a meter, then, or 33 centimeters, then we need 3 diopters of accommodation. So therefore, if an object is actually placed at 10 centimeters, which is 1/10 of a meter, we need 10 diopters of accommodation. So a person at age of 20 can look at near objects very close to the eye, that is at 10 centimeters. But as your age increases, the accommodation amplitude decreases to 7 diopters at 30 years of age. If it is 7 diopters, that means the near point recedes to around 14 centimeters, means that you will be able to see near objects only at 14 centimeters, and if you move them closer, they will be blurred. At 40 years of age, the accommodation amplitude is only 4 diopters. At 50 years of age, it's around 2 diopters, and at 60, it is only left to 1 diopters. The symptoms of presbyopia are reduced near vision, which starts at around 45 years of age. There is a lot of fatigue due to near work at 45 years of age, and ultimately they develop poor near vision. There can be headache and inability to read the small letters. Especially persons who read newspapers, they start having these problems early, since the newspaper letters are fairly small. Presbyopia treatment is giving spectacles only for near, or adding near spectacles to the distant spectacles that the person was previously using. So according to the loss of normal accommodative amplitude, at 45 years of age, a normal person requires a near add of about 0.5 to plus 1.25 diopters, and it increases to 1.5 at the age of 50, to around 2 at the age of 55, and 3 at the age of 60. So that if a person wants to read at 1/3 of a meter, he needs 3 diopter of accommodation. But now, because the person cannot accommodate, so we give him a +3 lens to put on the eye, so that he can see at around 1/3 of a meter. You should never overcorrect these people because they are not able to accommodate, and you should also check what is the safe reading distance. So if a person is sitting in front of you, you should ask the person to hold a book and read it and see what is a comfortable distance for that person, and accordingly you should correct the person. First method of correction of refractive errors is actually spectacles. Spectacles can be unifocal, where the focus is only for a single point. Glasses are unifocal glasses. This is a minus lens which is used for myopia because it is causing minification of the image that is presented to the glass. This is a plus lens, but because this is an aphakic glass, the lenses are fitted inside of the actual frame to make the glass lighter. The bifocal glasses, they are of two types, executive type and the normal bifocals. The normal bifocal area is placed in the bottom of the glass, and in the executive type bifocal area, the near ad is which is actually present in the bottom part of the glass. It should actually bisect through the center of the pupil of the child. Usually children who need near ad, who have excessive convergence for near, they are given a near ad. These children, they need executive type of glasses. Now this is an example of progressive glass. A progressive glass, in the upper part you can see the image expands as it goes down. Why is this expansion happening? This expansion is happening because the plus ad in the glass is constantly increasing from top to bottom. So when the person is looking from the top of the glass, he looks at the distance objects clearly. From in between the glass, the intermediate, and from the bottom of the glass, the near objects are actually seen clearly. Progressive glasses are very good options for people who are who have desk jobs and who have to work on the desktops, because they have to look at the far objects, the intermediate computer that is present around at 1 arm's distance of the person, which is not the normal reading distance, but they also have to keep something on the desk and copy. So the progressive glasses are best for people who have desk jobs. Now the material of the spectacles, they can be made of glass lenses or plastic lenses. Glass lenses, that is usually made of crown glass. Crown glass is very thick and heavy and it might shatter on falling. The plastic lenses are the commonly ones used, and the common lenses are the resin lenses, which have thick lenses with low refractive index. Nowadays, high refractive glasses are also available. People who have more than 4 diopters of hyperopia or myopia, they can use a high refractive index glass, so that the thickness of the glass that they are using is not so much, which makes their glasses lighter for the person to wear. Polycarbonate lenses are also available. Polycarbonate lenses are very lightweight and they are non-breakable, but they can be easily scratched. Coming to contact lenses are of 3 types. Hard contact lenses, which are formed of PMMA, polymethyl methacrylate. They are impermeable to oxygen and they can lead to corneal abrasions if not properly made. Then we have rigid gas permeable lenses. They are made of cellulose acetate butyrate. They are highly oxygen permeable. They are used commonly. Soft contact lenses are the ones that are readily available for wearing in each refractive error. They are made of HEMA. They are fairly glass permeable. This is hydroxyethyl methacrylate. They are comfortable for wearing. People can wear it themselves at home. But there is biofilm production that can occur onto the soft contact lenses if the contact lens solutions are not properly used, if the hand washing is not properly done. It is important that when you are using contact lenses, hand washing and the technique of putting contact lenses is learned before starting to use contact lenses. Indications of contact lenses is pretty much every refractive error person can use contact lenses. If there is anisometropia, where say one eye has +4 and the one eye has +10, there will be a lot of difference in the image magnification that is occurring in both the eyes. If there is more than 5% difference of image magnification between the two eyes, then there will be anisoconia, which means that the person will have a double vision, or person will see bigger image with one eye and the brain will not be able to fuse those two images into one. If there is very high refractive error, then also a person should use contact lenses. For irregular astigmatism also, rigid contact lenses are recommended. Cosmetic contact lenses for blind eyes are actually also available if there is corneal opacity. Bandage contact lenses for small corneal perforations can also be used. Bandage contact lenses are around 14 millimeter in diameter. These are large bandage contact lenses. They can be put over the cornea if there is a small perforation happening in the cornea which does not require any treatment. Drug delivery contact lenses are also present for glaucoma nowadays. In fact, a contact lens has also been developed named SensiMed for intraocular pressure measurement in glaucoma. Now we'll be talking about refractive surgeries. Refractive surgeries, they can be cornea-based procedures or the lens-based procedures, because cornea contributes 43 diopters to the whole power of the eye out of 60 diopters, and the rest is contributed by the lens. So these two can be manipulated to change the power of the eye so that the rays that are not focusing on the retina are made to focus on the retina. The corneal procedures are radial keratotomy, LASIK, intracorneal ring segments. The lens-based procedures are lens exchange or phakic IOLs that can be used. What is the principle of refractive surgery? For myopia, because in myopia either the axial length is bigger or the curvature of the cornea is more. So the curvature of the cornea can be reduced by corneal flattening. That can lead to disappearance of myopia. In hyperopia, the cornea might be flat, so we have to steepen the cornea to get rid of hyperopia. Or we can put a minus lens in the side of the eye for myopic people and plus lens inside the eye for hyperopic people. Talking about LASIK. So what do we do in LASIK? In LASIK, above the cornea we create a flap. So from top of the cornea we create a flap. We move that flap away, and in this area we ablate this part of the cornea in the center. So when we ablate this part of the cornea in the center, the cornea becomes flatter, but the corneal thickness also decreases. Excimer laser is the laser that is used to ablate the cornea in LASIK. So you make a flap, ablate the cornea, make it slightly flatter and replace the flap over the eye. What are the indications of LASIK? It is very important that whenever you are thinking of correcting any refractive error, you should consider the following: that the person is not having any progression in the refractive error for the past 2 years. Moreover, the person has not used contact lenses for the past 2 to 3 weeks, so that there is no deforming of the cornea that has occurred due to presence of the contact lenses. So the age should be more than 21, this refraction should be stable. It could be a myopic, hyperopic or astigmatism person. Because we are making the cornea thinner in the center, the residual stromal thickness should be at least 250 microns, which is recommended, and overall thickness of the cornea should be more than 350. The contraindications to LASIK are very important. Keratoconus, where there is already thinning of the cornea. Fuchs corneal endothelial dystrophy, because the endothelium is already damaged, it might get damaged more. Any other basement membrane dystrophy of the cornea, if there is infection in the eye, or there is other glaucoma or retinal diseases which may be affected by doing a LASIK surgery, there you should not do LASIK. LASIK can result in dry eye. So if the person already has a dry eye, you should recommend that person to not get a LASIK done. Nowadays, we have SMILE, which stands for Small Incision Lenticule Extraction. So what did we do in LASIK? We had to create a flap. But now that we have femtosecond laser, which makes a lenticule inside the cornea. So inside the cornea, the laser goes and cuts out a lenticule and makes an incision on one side. From that incision, we separate this lenticule and take it out of a small incision. Now the flap related problems like flap loss or flap disinsertion, these problems have been alleviated because of the smile. Advantage over LASIK is that corneal sensation remains the same and the dry eye is lesser. Talking about photorefractive surgery, photorefractive surgery is done where you do not make a flap or a lenticule. You just take out the epithelium over the cornea and abrade the cornea and put a contact lens over it until it epithelializes. In thin corneas, in dry eye syndromes, we can do photorefractive keratotomy. Radial keratotomy was earlier used, is nowadays obsolete. Radial incisions of up to 80% thickness of the cornea. So, in the cornea, leaving the central 3 millimeters, 80% thickness simple incision would be given on each side like this. 8 to 16 incisions of this sort were given. This would flatten the central part of the cornea, which was called the optic. Intracorneal ring segments like these can also be used. They are made of PMMA. This is hard material. So, when these intracorneal ring segments are inserted inside the stromal thickness, you make a simple cut in the cornea and you insert a ring segment in the cornea. They pull and flatten out the cornea. So, when you put an intracorneal ring segment, they pull the cornea outwards and flatten the central corneal surface, leading to disappearance of myopia. Refractive lens exchange is that you do a phacosurgery even though there is no cataract. The advantage is that it can be used in people who are slightly older, or a 50-year-old myope has come to you and he wants his refractive error to disappear at this age. In those cases, because cataract will anyway develop in another 5 years or so, so then you can do a refractive lens exchange in those people. Phakic IOLs. Phakic IOLs are usually done in young hyperopes or myopes. A lens is placed behind the iris but ahead of the normal lens. So, you can see that there is a reflection here and here. The reflection here is the normal lens and this is the reflection of a thin lens which looks like a button. It is placed in front of the iris. So, there is central part called the optic and the outer part is called the haptic. This lens is actually inserted behind the iris after dilation of the pupil. It is very important to do a PI in these cases because these lenses are right behind the pupil. They can cause pupillary block glaucoma. Nowadays, the lenses that are coming, they have holes right in the center and the side of the haptics to avoid development of angle closure. There, because there is a small hole right in the center of the optic, the aqueous keeps escaping from there. It is usually made of Colomar and these lenses are called implantable Colomar lenses. So, now coming to the role of refractive error correction in a person with headache. So, when does a person who has come to you with headache, you should correct them for refractive error. If there is mild to moderate refractive error, that can lead to headache in a person. In early presbyopia also actually headache can happen and it is usually more common in hyperopia. 6 to 10% of refractive error people may present with headache. It is symptomatic when they have prolonged visual tasks. So, the International Headache Society classification tells you when to attribute a headache to refractive error. So, causation, at least 2 of the following should be happening in the person, that the headache has developed and significantly worsened with the onset of the refractive error. Second of all, headache has significantly improved after correction of the refractive error and it is aggravated by prolonged visual tasks and it improves after the visual task is discontinued. So, this kind of a headache can be attributed to a refractive error, but if it is associated with aura, it is an intermittent, very severe headache and there is headache despite wearing refractive glasses regularly and patient has diminution of vision which is not corrected by refraction, or there is nasal discharge with pain that comes in clusters in a cluster headache, these kind of people should be referred to a ophthalmologist so that the fundus can be visualized and to the neurologist for looking at any related causes of headache. So I have covered all the refractive errors and the refractive surgery and the headache which can be attributed to refractive error. It is very important to remember why and how it happens and when do you have to refer a patient. Now going on to the MCQs. What is false regarding myopia? So what is false regarding myopia? The eye is longer than usual. Yes, that is true. Do they have a flat, flat cornea attribute to myopia? No, a flat cornea does not attribute to myopia. Anterior displacement of lens can cause myopia. Yes, that is true. And high refractive index of the lens can cause myopia. That is also true. So the answer is a flat cornea. Steep corneas actually lead to myopia. So a 66-year-old lady who used only near glasses earlier, that means her distance vision was good, now presents with reduced distance vision but improved near vision. What is she a case of? Cataract, index myopia, retinal detachment or corneal degeneration? So let's go one by one. What will cataract do? Cataract will reduce the distance as well as near vision. If there is a retinal detachment, there will be a decrease in distance as well as near vision. Similarly, in corneal degeneration also there will be a decrease in distance as well as the near vision. But in index myopia, the distance vision will decrease and the near vision will become better. So the answer here is index myopia. Last but not the least, all is true about hyperopia except first is small eyes. Yes, they have small eyes, shallow anterior chambers. Do they have poor accommodative effort? No, hyperopes usually over accommodate and they have high accommodative effort. Pseudopapillitis can be present in hyperopia because of very small and crowded optic discs. So answer is poor accommodative effort. Thank you very much. I hope you have enjoyed and learned from this lecture. Thank you.